Thank you. Thank you so much for the invitation. It's always a pleasure to be here every year. I have to thank my vascular colleagues at Sinai for their collaborative work. We have a very, very tight relationship. We do most of these cases actually together anytime we go in the arch. And so much so that now their junior residents spend a month with us in the OR watching aortic surgery, which I think is very useful and will come in very handy one day when they're in practice. So anyways, my task this morning is to take you a little bit away from the descending aorta into the ascending aorta and arch and talk about the open management of type A dissections. Most of the talk will be based on these most recent AATS, that ECD document that came out on the management of acute type A's, which I think is a very, very comprehensive document, both for type A's and type B's. So I invite you to all look at it if you're interested in digging a little deeper. Of course, what we're trying to prevent with an acute type A is death of the patient. And as you know, acute type A dissection carries a very high risk of mortality. It's around a 1% mortality per hour for the first 48 hours. So if left untreated, or at least untreated surgically, almost half these patients will die within the first couple of days. So this is a surgical emergency. And the reason they die is malperfusion proximally. They can malperfuse their coronaries. They can have acute aortic regurgitation because the commissures just drop and the valve becomes incompetent, and acute AI is very poorly tolerated. They can die because of stroke and malperfusion to the head or elsewhere, or they can die because of cardiac tamponade. So that's what we're trying to fix at the time of surgery. So early survival in a type A is dictated by malperfusion. But what is also important and has become more and more relevant to us in practice, now that we've managed to make these operations much safer, we're now thinking what happens to these patients in the long term. And when you think about their long-term prognosis, their late survival, it really depends on the remodeling of the distal aorta and aortic growth distally. So the decision points for us in the operating room when we see these patients is cannulation strategy, how are we going to protect the brain, how are we going to manage malperfusion, how are we going to manage the aortic root, and how distally should we extend our repair. And I'll focus on the last 2 points rather than, because in the interest of time. So how do we manage the root, and what do we do with the aortic arch? So in terms of the aortic root, this is what that document will say. Essentially, the aortic valve resuspension is recommended for most patients. And what I mean by that is when you have a dissection, you delayer the aorta and the commissures drop in, which makes the valve completely incompetent. That's almost ubiquitous finding in all these patients. So what you need to do is restore commissural integrity, what we call aortic valve resuspension, in order to fix the AI. And then the aortic root, whether replaced or not, really depends on several factors. The mechanisms of AI, as I said, is detachment of one or more of the commissures, which leads to prolapse of the cusps, and also in some patients they have dilatation of the sinotubular junction if they had a pre-existing aneurysm. But the vast majority of these patients actually have normal aortic valves prior to the dissection. So in the vast majority of these cases, we shouldn't really be looking at replacing the valve, because then we're introducing a whole new potential set of issues if we use prosthetic valves. And so for most patients, a sinus-preserving approach is just enough. And what we do, as I mentioned earlier, is there's always going to be a delayering of the aorta, but you bring the layers back together. You tack the commissures here so that you restore valve geometry and valve function. And then with regards to the aortic wall here, you will bring it back together either by inlaying the adventitia or by using a felt technique. So this is an example of this operation. This is an acute type A. You see the hematoma in the aortic wall. The only thing keeping that patient from dying is the adventitia. That's why the aorta has not ruptured. It is only dissected at this point. The aortic root is not dilated. This is not a patient with connective tissue disorder. And the aortic valve, as you see, is trileaflet and pretty normal. So that's a valve that we're going to preserve. And so you see we put these pledgeted sutures at the level of the commissures to resuspend each of the 3 commissures, and that will restore the geometry and the structure of that valve. And you see how the valve looks once that is done. It looks like a normal valve. And then the next step will be to run a layer to reinforce that that sinotubular junction to avoid any continuous flow into the false lumen, and then finally put a Dacron graft after having done the hemi-arch replacement here. For resuspending the commissures, you want to make sure that this is long-lasting, that the root does not expand over time, so you want to really eliminate any flow into the false lumen. So you want to make sure that there are no re-entry tears in the aortic roots. You can use an inner felt strip or adventitial overlay, as you can see here, which is my favorite technique. Some people will use what they call a neomedia, which is a felt strip or a felt patch that they'll put between the intima and the adventitia. Not a big fan of doing so, but that's another way of reinforcing the root. This is an example of a 34-year-old female patient with Loeys-Dietz syndrome who's 5 months after resuspension of the aortic valve, and you can see here a big re-entry because of absence of reinforcement of that suture line. And what that does is the root then expands very rapidly, and we have to re-intervene on these patients. So that's something that you want to avoid. Now, which patients do we have to replace the aortic root in? It's, according to guidelines or that ECD, it's patients who have a root aneurysm or an entry tear in the root. I'd also argue for young patients, it's probably wiser to replace the aortic root because it's really suggestive of some aortopathy or connective tissue disorder. And there are different ways we can replace the root, either with prosthetic valves in a conduit or doing what we call a valve-sparing aortic root replacement. Patients with a syndromic aortopathy should have their roots replaced in almost all cases. The reason being, if you don't do so, there's a very high rate of these patients requiring reintervention if you only do a supracommissural ascending aortic replacement. So these roots need to be replaced. So when do we spare the valve instead of replacing the valve with the root altogether? Obviously, if there's surgical expertise, but mainly in young patients, those who are hemodynamically stable, this is a slightly longer operation than just doing a regular Bentall. And of course, if the leaflets are of good quality. You always have to balance long-term benefits with operative risk. This holds true for any operation. But by and large, a valve-sparing operation results in better long-term outcomes for patients than a Bentall procedure. And now, what about the distal aorta? And that really is a bit more at the cross-section of what you guys do and what we do. How do we manage the aortic arch? Certain conditions may require an extended arch replacement. The basic sort of repair in an acute type A is just to replace the ascending, do a hemi-arch, and so that we save everything that has to do, that is intrapericardial. But on the other hand, we always have to think about what's happening in the arch. So if there's an entry tear in the arch, if the arch is dilated, if the patient is young, if the patient has a connective tissue disorder, these are all patients in whom we'll consider a more extended approach. And there are different ways that it can extend our repair at the time of a type A repair, using either a bare stent, antegrade TEVAR technique, a zone 2 arch with a delayed TEVAR if needed, or a total arch with a frozen elephant trunk technique. And the goal is really to reduce early malperfusion and to reduce late reintervention and hopefully improve long-term survival of the patients. So if we look at them one by one, this is the AMDS device, which was recently acquired by Artivion and recently approved by the FDA for use in acute type A. It's a bare nitinol stent with a proximal felt cuff, has large wire crosses. It's an adjunct to a hemi-arch repair, so it keeps the operation as simple as it comes. It's a zone 0 anastomosis, and this is deployed antegrade into the true lumen. It crosses over the head vessels, just like a petticoat technique that was just described. Because of the large wire crosses, it restores flow in the true lumen, but it doesn't obstruct vessel perfusion. That felt cuff, what it also does is it prevents these danes from happening, which oftentimes maintain forward flow into the false lumen and can lead to reinterventions down the line. So it restores flow in the true lumen, it pressurizes it, and it decreases or decompresses the false lumen in order to improve remodeling of the aorta. There's good data recently now, 5-year outcomes using that device showing very good aortic remodeling in these patients. So it's very easy to use. There's no risk of spinal cord ischemia, and it's a pretty useful device in some cases. This is an example of a 70-year-old patient who presented with acute type A. This is going a little fast. I'll show you the stills. There was a malperfusion of the left carotid, as you can see here. He had left perfusion of the left femoral, as you can see here as well. The patient was hemodynamically unstable. The entry tear was in the ascending aorta. So we used the AMDS device, and pre-discharge, you can see here, the left carotid is completely patent, and the left femoral was completely open, and you can see the device across the arch here nicely deployed. So this is a very nice recent adjunct to aortic arch, extended arch repair in certain patients. What about an antegrade TEVAR? So this is still a hemi-arch replacement, so you're not reimplanting the head vessels, but you're doing a hemi-arch repair and at the same time deploying a stent graft in the descending aorta. Eric Rosselli in Cleveland dubbed it the Be Safer technique and has championed it. It's a nice approach. There's a single branch into the left subclavian to stabilize the stent graft here. And there are commercial devices that will be coming to market, or at least to study, that we'll be investigating very soon, the Arcevo device that might serve as a good adjunct in these cases. The benefits is that it's easy, it's still a hemi-arch approach, it may improve malperfusion and late remodeling. However, there's always a small risk of spinal cord ischemia anytime you deploy a covered stent into the descending aorta. The zone 2 arch with delayed TEVAR is relatively simple. It's still an arch replacement, but there's nothing more to do to it. It takes care of most malperfusion and arch issues. It obviously minimizes the risk of cord ischemia. It's very cost effective, and the TEVAR is then deployed only and if necessary down the line, which is probably a very reasonable way of doing things. The last approach is a total arch frozen elephant trunk approach. This is an example of a 50-year-old patient who presented with an entry tear in the arch, a very compressed true lumen, as you can see here, and distal malperfusion. And so that's the kind of patient in whom we will replace the whole arch. We debranched the innominate, the left common carotid, and deployed a Thoraflex in the descending aorta. And you can see afterwards that the malperfusion is fixed, and the patient did well thereafter. So the pros is that it minimizes the risk of reintervention long term. It treats the entire arch. It's a stable platform for open or endo-distal interventions, but obviously it's technically more demanding. It certainly comes with a higher operative risk in less experienced hands, and the risk of spinal cord ischemia is not zero. So that's the panoply of options we have in terms of technical ease and completeness of repair. This is kind of how it works. There are studies, randomized trials that will look at different approaches, including importantly hemi-arch versus total arch replacement in the setting of a type A dissection. This study is ongoing in Canada right now. It will be interesting to see the results of that. So in summary, type A dissections remain a challenge. The aortic root has to be replaced if there's a root aneurysm, an entry tear, or connective tissue disease, and a valve sparing or a Bentall is depending on patient age, condition, and surgical expertise. And the aortic arch, there are multiple options, and obviously one has to tailor the approach, balancing the early risk versus the late benefit of such approaches. Thank you.